Yes, ma'am. Good evening, everyone. I'm Dr. Binakshi, and it gives me immense pleasure to welcome you all to our second series of clinical rounds with Jindal IVF. Before the festive season, we had conducted our first series where we learned regarding the basics of infertility and IVF over 6 different sessions. This series 2 shall include 6 sessions where our experts will be covering induction and stimulation protocols and shall share both evidence-based insight and experiences. We really hope that this series will serve as an interactive and enriching learning journey for all our participants. For this session, it is regarding the ovulation induction with oral agents, and it is my honor to welcome our expert for the session, Dr. Umesh Chindal ma'am. She's director of Jindal IVF and a distinguished authority in the field of reproductive medicine and infertility. She's a pioneer in ART in Chandigarh. And with years of clinical experience, numerous publications, and deep commitment to advancing the fertility care, ma'am has been a guiding force to many clinicians and students like myself. We are obliged to have you, ma'am, and I thank you for joining us. As our speaker, we have, it's my pleasure to welcome Dr. Manishi Mittal, Director and Senior IVF Consultant, Mittal Nursing Home, Yamuna Nagar, Haryana. Ma'am has an extensive experience in managing infertility and reproductive disorders and has been actively involved in academic teaching and research. She has authored many chapters in our Indian textbooks of gynae and infertility. I welcome you, ma'am, and I request you to kindly lead us into the session.
Good evening, everyone. I welcome you all to the second session of clinical rounds with Jindal IVF. And after covering all the basics of infertility, now we'll move on to the management of the infertility cases. So we are starting with the basics of management, that is ovulation induction with oral agents. So what are our learning objectives? Basically, I'll be covering the physiological basis for ovulation induction, commonly used agents, their role, their comparison, and how to use them in common case scenarios. So basically, what is ovulation induction? Ovulation induction is basically the treatment aimed at stimulating development and release of one or more eggs from ovaries in women who do not ovulate regularly. That is, they have irregular cycles and or they have evidence that ovulation is not there. And contrasting to this, we have controlled ovarian stimulation and super ovulation, where controlled ovarian stimulation is used in ART cycles to produce multiple eggs in the same cycle, and it is practiced in both ovulating and non-ovulating women. And super ovulation is basically in uh, cycles where we want 2 or 3 follicles in already normally ovulating women. So that is the basic difference. And ovulation induction we are using in anovulatory women. So anovulatory women can be divided into 3 categories according to WHO. Out of these, group 1 and group 3 are those which are not amenable to treatment with oral drugs, because group 1 is hypothalamic failure and group 3 is end organ failure, that is hypergonadotropic hypogonadism. In these 2 groups, oral drugs don't work. But the most common group is the group 2, that is eugonadotropic hypogonadism, most commonly presenting as polycystic ovarian syndrome. It is commonly causes infertility in 20 to 40% of cases, and it is amenable to treatment. It is very easy actually to treat. So in fact, we can say that the group 2 ovulatory disorders have a good prognosis. And the oral agents are the first line due to the ease of their use, cost effectiveness, and lower risk of hyperstimulation in these. The commonly used oral agents can be divided into 2 categories: the SERMs or selective estrogen receptor modulators and the aromatase inhibitors. The SERMs were the first ones to arrive on the scene. Clomiphene citrate has been used in ovulation induction since 1956. It became commercially available in 1961. It was followed by tamoxifen, and then in 2001, the scientists started using aromatase inhibitors in ovulation induction. These were previously used in breast cancer. The basic difference in both of these is their mechanism of action and pharmacodynamics. The SERMs are long acting, Their action lasts for 5 to 7 days, and the aromatase inhibitors are short acting. They are early absorbed within 1 hour. We can see the levels in the serum, and action because the half life is around 42 hours. Mainly, the uses are basically the same. The SERMs are used in anovulatory cycles, unexplained infertility for IUI, luteal phase defect, male infertility. And similarly, aromatase inhibitors are also used, but aromatase inhibitors called more suppression of estrogen. So they are used in endometriosis related infertility and fertility preservation also. The advantages of SERMs like clomiphene are basically a wider area of experience with clomiphene is there. It is inexpensive, highly effective, and user friendly. And the advantage of aromatase inhibitors is that uh, the SERMs they block the central mechanism, which is not seen in aromatase inhibitors. So we can see monoovulatory cycles with this. And because they don't have any effect on the endometrium is better with aromatase inhibitors. Disadvantages of clomiphene are hot flushes, mood swings, headache. All these disturbances are more with clomiphene. And in addition, the endometrium may be thin and multiple pregnancy chances are more. Aromatase inhibitors, in contrast, they are well tolerated, but sometimes headaches, nausea, cramps, hot flushes, extra can be seen. They have similar efficacy, with clomiphene giving a 60 to 85% ovulation rate and 10 to 20% pregnancy rate. Aromatase inhibitors giving 70 to 85% ovulation rate and 20 to 27% pregnancy rate. Contraindications are similar: pregnancy, liver disease, renal disease, etc. So, how do these act basically? This is the normal hypothalamic pituitary axis where the hypothalamus releases GnRH, which acts on the pituitary to release LH and FSH, which acts on the ovary. The FSH acts to produce follicles, and then estrogen and progesterone is produced later on in the cycle. The follicles produced estrogen, and estrogen gives negative feedback on both the hypothalamus and the pituitary to stimulate uh, to stop secretion of FSH. So, how do the ovulation induction drugs act? So, first of all, clomiphene, it is a selective estrogen receptor modulator. So, the receptors in the brain, the hypothalamus and the pituitary, they are blocked because by clomiphene. So, once they are blocked, the negative feedback effect of estrogen is not there. So, since negative feedback effect of estrogen is not there, it stimulates the secretion of FSH. FSH stimulation is increased, and therefore it leads to more follicular growth. So follicular growth is stimulated, and in case of anovulatory cycles, where the follicle is not getting developed, follicle starts developing. And because clomiphene is longer acting and it blocks the receptors for a longer time, so the action on FSH acts for a longer time. So it can lead to multiple follicular development. And in case of letrozole and anastrozole, they are aromatase inhibitors. Aromatase is the enzyme that converts androgens into estrogens. So it blocks the conversion to estrogen at that level. And the estrogen, therefore, it is decreased. And because it is decreased, the negative feedback over the hypothalamus and pituitary, that is decreased, which leads to increase in the release of GnRH and FSH, which in turn leads to follicular growth. So that is the difference in mechanism of clomiphene and aromatase inhibitors. So what is the advantage in case of letrozole? Because it acts at the peripheral level, it does not act at the central level. So it does not block the feedback response. So once the follicle starts developing, follicle produces its own estrogen, and then the estrogen level, when it rises, it causes negative feedback, which leads to decrease in level of FSH. So we don't have multifollicular development, we have a monofollicular development, which decreases the chances of OHSS and multiple gestation. That is one advantage. Second advantage is that the level of ovarian androgens is increased. Nowadays, more and more studies are coming out that in case of initial follicular development, when the follicle size is small, the high androgen levels they increase the FSH sensitivity of these follicles. So in cases of poor responders also, aromatase inhibitors increase the androgen level, which leads to increased sensitivity of the follicle to FSH. So stimulation becomes easier and better in these. So now that we have covered the basic, we have a very common case scenario that we face daily in our OPD. We have a lady who is 28 years old, married for 1.5 years, primary infertility. She has irregular cycles. There is no other significant history, and there is no male factor in this patient. The BMI of the female is 24, that is higher than normal. Otherwise, examination is normal. Examination of male is normal. On investigation, the ultrasound shows polycystic ovaries, and the hormones show a high LH level. Thyroid and prolactin are normal. AMH is 5.5, which is also on the higher side. The semen analysis is normal. HSG has not been done. She has not taken any treatment yet. Only investigations have been done. So, what is the diagnosis? Can we presume that she is PCOS and anovulatory? And is this hormonal profile suggestive of PCOS? So, definitely, she is anovulatory. How do we define irregular menstrual cycles? In cases 3 years post menarche to perimenopause. If the cycles are less than 21 or more than 35 days apart, or she has less than 8 cycles per year, we define those as irregular menstrual cycles, and those will be anovulatory. Then, when irregular menstrual cycles are present, diagnosis of PCOS should definitely be considered. And how do we diagnose PCOS? We follow the Rotterdam criteria, which includes
Sure.
presence of any two of the three criteria. First is the irregular cycles, which are seen in this patient. Second is polycystic ovaries on ultrasound, which is also seen in this patient. And excessive androgen, which may be clinical or biochemical. We have not investigated in this patient, but she has not shown any clinical signs. But still, because two of the criteria are present, we can consider this patient as PCOS. So once PCOS is established and ovulatory, how do we treat? So before treating, do we need any other test? So we have to fulfill the prerequisites first. We have taken her history and physical examination, duration of infertility, age of the patient, what is the cause, a baseline pelvic ultrasound, hormonal levels, prolactin, thyroid, and pituitary function, and evaluation of male partner. All these have been done. So next is the HSG, which has not been done. Is it really necessary to do the HSG or endometrial biopsy for this patient? She has not taken any treatment before. I would like any of the listeners to comment whether they would like to do HSG or endometrial biopsy for this patient before going for ovulation induction.
Manishi, I think you have already given the answer that PCOS, if you do not suspect any pelvic pathology, there is no history of previous pregnancy, abortions, infection, PID, tuberculosis, anything, you can, especially young patients, short duration of infertility, you may not get an HSG done. HSG is more indicated if uh, it's a prolonged infertility or you're thinking that you might be giving gonadotropins, then HSG is usually recommended. But with the simple first few cycles of ovulation induction, you may not get HSG, or if ovulation is there and pregnancy is not happening, then perhaps you will think of HSG.
Yes, definitely. This is what the international guidelines also say. And we also have to consider what is the population criteria in that population. Like in our population, in few places, there is high incidence of tuberculosis, pelvic tuberculosis. In those patients, we can go for HSG early. But as a routine, we don't have to go ahead with in the initial investigations.
The same is true of EB also, because now we don't need to confirm an ovulation with EB, But EB again may be indicated when if there's prolonged amenorrhea and you want to rule out any hyperplasia, or you want to rule out tuberculosis, then EB may be indicated. And routinely, even EB can be skipped in polycystic ovarian disease cases.
So moving on to the management, how we have different options. How would you all like to manage this patient? First is a lifestyle only. Second is along with lifestyle letrozole 2.5. Third is clomiphene 50. Fourth is letrozole 5 mg, and fifth is clomiphene 100. Or we can start directly with gonadotropins. So what would you like to start?
Binakshi, what do you think? Let me
Ma'am,
ask the youngsters who are there.
ma'am, we can start with the lifestyle management and low dose letrozole. This patient.
There's one answer in the chat box. One
Lifestyle.
is lifestyle, then second is lifestyle plus CC 100. Any other answers? Vinakshi, what did you say?
Ma'am, lifestyle with low dose letrozole.
2.5.
Yes, ma'am.
Yes, Manishi, what would you like?
So all these options are there. Definitely ovulation induction, we will go ahead with this because patient is not that obese, so we can directly start with lifestyle and ovulation induction. And especially because now we have very simple, cheap and effective drugs, and we can also have monofollicular development, so we can go ahead with this. So latest recommendations are letrozole. The first line treatment is letrozole for anovulatory women with PCOS, and especially no other infertility factors. Lot of places letrozole is still off label, uh, and where it is not allowed, the recommendation is that clinicians should use other ovulation induction agents. But in India, letrozole has been allowed for use in ovulation induction. So our first choice should be letrozole.
Manishi, would you like to comment that why letrozole is preferred? Because recommendations are very clear now for PCOS that letrozole should be the first choice. You have highlighted earlier, but could you highlight salient features why letrozole is first line?
Yes, like I covered in the mechanism, basically letrozole is short acting. So the effect of letrozole, the any side effects or anything that is there, it disappears by the time of ovulation. So we can quite safely give letrozole. Another thing is letrozole has monoovulatory action. So monofollicular development is there. So there are less chances of multiple gestation and less chances of OHSS, which can be seen in clomiphene, even if it is rare. And with gonadotropin, definitely chances of multiple gestation and OHSS are more. So all these problems are not seen with letrozole. So as a first line start for a patient who has not taken anything else, letrozole is definitely the best choice. And
And
another thing is the side effect on the endometrium is not there, which is there in clomiphene. The peripheral action is not there.
yeah.
Ma'am,
Third, and
sorry.
Bolo, Binakshi?
What shall be the role of insulin sensitizers in such patient?
Yes,
Along.
insulin sensitizers also we can give, that I am covering later on in this presentation. But the international guidelines also say that for letrozole, they say that first line letrozole only can be given. But if we are giving clomiphene, preferably we should add insulin sensitizer like metformin to it. We can give insulin sensitizers only also, and especially if the patient is showing evidence of insulin resistance, we need to do a GTT also in PCOS patient. And if signs of insulin resistance are there, definitely we should give insulin sensitizers. And even if the it is not there, PCOS basically has insulin resistance as a part of the pathology, so we can add insulin sensitizers. And in the recommendation for clomiphene especially, we should add metformin. And if we are giving clomiphene, we should explain to the patient that chances of multiple pregnancy are more.
Right, ma'am.
But
Thank you.
alone, metformin alone has a lower success rate as compared to clomiphene and letrozole. So
Yes.
metformin alone should not be given. Metformin with clomiphene is a choice.
Yes. Metformin can be combined with letrozole also, and alone it has a less effect. So now that we know the agents, what dose should be given? So starting with letrozole, multiple studies have lot of studies with lots of regimes have been done with letrozole. Main basic that starting dose is 2.5 milligram for 5 days. That is the standard dose that is used for letrozole. First thing we should know is why it is so. So 2.5 milligram dose, it was adopted from the dose of letrozole. Letrozole is basically a drug used for treatment of breast cancer. In that situation, 2.5 milligram dose is used. So that's why same dose for ovulation induction. And 5-day treatment schedule was taken from the clomiphene regime, and the administration starts on day 2 to 3 to get the maximal effect. That is also similar to clomiphene. Now, over the years, what studies have shown that even the duration can be extended to 7 to 10 days or even 12 days people have given, and the dose can be increased from 5 milligram to 7.5 to 10 to even 12.5 milligram dose has been used. So a lot of studies have shown that 5 milligram gives a higher number of follicles and a higher pregnancy rate. And still avoiding multiple gestation. Even if more number of follicles are there, it is still chances of multiple pregnancy are less as compared to clomiphene, but pregnancy rates are higher as compared to 2.5 milligram. And many even the latest 2024 studies have shown that a higher dose or a longer duration for 10 days, 2.5 milligram for 10 days, both show a better pregnancy result as compared to 2.5 milligram for 5 days. And increasing the dose to 7.5, 10 or 12.5, those studies have shown that follicles number may be more, but pregnancy rates have not improved. So 5 milligram seems to be the best dose. Single dose regime has also been done. A single dose of 20 or 25 milligram can be given on day 3 of the cycle. So that the advantage of this is that the effects will be over by the time ovulation is there. Early clearance of the drug will be there. So that, and a higher effect will be there in the developing follicles. So the chances of uh, hitting the developing follicle early is there. So it is assumed that it will have a better effect, the higher dose. The disadvantage is that it may have more side effects and multiple pregnancy may be there, but till now uh, very few studies are there which show the use of single dose, and they have not shown much side effects with their or multiple pregnancy also. They have given very positive results. So this is one dose that can be tried, but the information about this is limited.
Okay,
Ma'am,
Manishi, there's one.
yes,
Pinakshi, yeah.
we have a question, ma'am, from a
Yes.
participant. They have asked whether the 5 milligram dose is to be given in a divided manner.
Both can be done because the half life is 42 hours. So 5 milligram dose can also be given, and 2.5 milligram twice a day can also be given. It does not have much difference. No studies as such have shown, but my personal experience is I have used both the ways, and there is not much difference in the side effects or the effects. Both can be done.
I hope we have answered your question, ma'am.
So next is clomiphene. Clomiphene, as we all know, starting dose is 50 milligram per day for 5 days, starting from days 2 to 5. And if multiple follicle development is there, we can decrease the dose to 25. And if ovulation is not there, we can increase by 50 milligram every month. A maximum 250 till 250 milligram can be given in according to studies, but practically we go up to 150 milligram only, because more than that anti-estrogenic effects are more. And the ovulation rate, as we all know, is very good with clomiphene. The conception rates also increase with the dose, but there is also increase in the risk of multiple gestation.
Actually, 150 dose ovulation may be achieved, but again, pregnancy rates are not increased. So, practically speaking, I have used 100 milligram only. 50 milligram, 25 milligram, yes, in young patients, in like this patient, I might use only 50 in the first cycle. And if multiple follicles are there, then 25 in very thin, lean, thin patients, 25 milligram we have also used in first cycle of clomiphene. So those risks are there, but these days now we prefer letrozole in high risk patients where a lot of follicles are there, the MH is very high. In those cases, letrozole does give a better result.
Yes, and chances of multiple pregnancy are also less. Definitely, chances of multiple pregnancy are more with clomiphene.
Yeah.
And we should explain to the patient also what is the problem with multiple pregnancy, because otherwise uh, patients don't understand. Now, moving on, after giving the drug, is any monitoring required for this? So, even for the first cycle, it is recommended that monitoring should be considered at least in the first cycle or when the treatment dose has to be increased. Because, first of all, we need to see whether the effect is there, whether the follicle is developing or not, whether ovulation is occurring or not. And secondly, we have to avoid multiple gestation and OHSS. For that, cycle monitoring is important. And how can we do the monitoring? With serial ultrasound and urinary LH kit. Urinary LH kit we can give to educated patients who cannot give multiple visits. Otherwise, gold standard is serial ultrasound if the patient can come easily to the center. Mid-luteal progesterone we are not usually doing. And serum estradiol levels also do not give that much information. That and in periphery, like in Yamunanagar, we don't get the reports also early. So preferably we do serial ultrasound only. Then how will you counsel the patient and what monitoring instructions would you give? So we have to explain to the patient what agent we are doing, how she has to take the drug, when she has to take the drug, what is the success rate. That is very important. We have to tell about the failure rate. We have to tell about the possible side effects. We have to tell what they don't, the warning signs we have to tell, for especially if we are giving high dose of clomiphene. So for that, some patients will feel distension and nausea, and all these are very common. With even with letrozole, these problems are seen in PCO patients especially. And we have to tell about lifestyle modification that should go simultaneously along with the drugs. Then we have to tell clearly the follow-up date for ultrasound or LH kit, how they have to do, and whether they want TI or IUI first, or before starting the drug only. It should be very clear to the patient.
Manishi, this
Yes.
LH kit, I think, is very commonly used for in metros and in especially patients who are coming from overseas. So, what instructions do you give for LH kit? When on which day to start and how to?
Yes, LH kit is a it is a very good method actually for educated patients and who cannot come repeatedly for ultrasound. It is a urinary kit just like a pregnancy test kit, and they can start on day 10 or 11 of the cycle, but it has to be done daily. And the day when the levels of LH start rising, that is that will come as positive on the kit. And we have to tell the patient that ovulation will occur around 24 to 48 hours after the kit comes positive. So they have to practice intercourse around that time. So we cannot give a fixed day for intercourse. We can tell that around 2 to 3 days after the kit comes positive, that after that they can have intercourse, considering the life of the sperm, which is around 48 hours, but life of the egg is 24 hours. So alternate days, if the patient is, it is very tough for, because mostly the LH kit will be taken by educated patients who have busy professional lives. So we have to explain to the patient that ovulation will occur around 24 to 48 hours after the LH kit shows a positive result.
Ma'am, we have a query. from a
Yes.
participant. They are asking whether an afternoon sample is required for LH kit.
Yes, LH kit, definitely the LH levels vary throughout the day, but anytime it can be taken.
No, it's preferable to do it around 10 a.m. in the morning, 8 to 10 a.m., because that is the time when LH is maximum. But there is no need to do twice, because anyway, the ovulation is going to occur 24 to 48 hours after the LH rise. So there's no point in doing twice.
Okay, thank you.
So now we have given the drug and we have started monitoring. So first ultrasound we usually do on day 8, 9 or 10. Commonly 10, on day 10 we do the ultrasound. So the first problem is that there is no follicle. So because it's the first cycle, we are seeing the response, no follicle has developed. So multiple options are there for us. We can either step up the dose, we can increase the duration of the treatment for the same dose, we can change the agent. If we are using letrozole, we can give clomiphene, or if we are giving clomiphene, we can give letrozole. We can add gonadotropins at this point, or we can drop the cycle and increase the dose in the next cycle. That option is also there.
So
If the,
what would be your preferred option in this patient?
so for me, the preferable option will be to step up the dose. We can,
Step up the dose.
if we are giving letrozole 2.5, we have started. We can go on to 5 milligram for 5 days. Then we can see the response. And usually, for such a patient, we will see a response. And in fact, in I have covered the stair-step protocol in your further slides. We can go up to 10 milligram, 12.5 milligram as a step up for letrozole, or we can give clomiphene also in the same cycle. That also usually gives a very good response. I won't like to give gonadotropins because this is the first cycle for this patient, and step up protocol is very good for these uh, when no follicle is developing.
Ma'am, if patient is not responding with clomiphene as we have started the patient on the dose, can we change it with letrose then also?
Yes, definitely we can change. If the patient is not responding to clomiphene, we can change to letrozole. And even without giving for such a patient, we should not give 2.5. We should straight away give 5 milligram because she has not responded to clomiphene. She is unlikely to respond to 2.5 letrozole. So 5 milligram we can give.
And ma'am, when to decide whether to cancel the cycle or not in case patient is not responding to the drug? How do we decide for cancellation?
Yes, if the patient does not respond to 5 milligram, also we can go on to 7.5. Theoretically, we can give to go up to 10 milligram also. But by that time, the patient also becomes very impatient, and doctor also becomes very impatient. So that is depends on how you counsel the patient. If patient is willing, we have to tell the patient that maybe after increasing the dose, also after changing the drug also, we may not get a response. Then we can start gonadotropins. Sometimes by this point of time with gonadotropins also we will not get a response. So after increasing to 7.5, we can drop the cycle, and then in the next cycle we can try again with, we can, instead of starting with gonadotropins, we can straight away start with a higher dose of letrozole and then add gonad. We can combine with the gonadotropins if with that also response is not there. And we can add insulin sensitizers also in the next cycle if we have
Okay.
not added before.
Ma'am, we have a query from ma'am. They have asked whether to start in next cycle. I request ma'am kindly elaborate your question.
Queries from whom?
Ma'am, you were telling about that we can change the age entry. In the next cycle, we have to change the age, not in the same cycle, right?
No, we can change in the same cycle also.
The
Like on
same
day 10.
cycle.
Yes. like on day 10 we have not seen the response with the starting dose, we can either step up the dose for the same agent, or we can change the agent also. If we have given letrozole, we can give clomiphene. If we have given clomiphene, we can give letrozole. In fact, studies have shown combined use also. I've shown that study also. In a few more slides I'll show you. Combined has also been used. So there is
Okay.
nothing like if one agent has been used, we cannot use the other agent in the same cycle. It can be done, but we have to do it gradually. Most important, we have to see that patient should not land in multiple gestation or OHSS. That is very important. For that, if we are giving additional agents, we have to monitoring is very important in those patients. Monitoring with
Okay.
ultrasound.
Okay. And Jindal, what are your views?
I think I do agree, but I think at our level, this type of patients come very uncommonly. So that's
Acha.
why this topic I had, selected her to deliver this topic. We the, very rarely we go to those extent. Even
Right.
patients to us is a different kind of population. You can
Okay.
understand that part.
Okay. Okay. Thank you.
Next problem is poor endometrium. This is mostly seen in clomiphene patients, but occasionally letrozole patients may also show poor endometrium. They can have a thin endometrium, or the pattern is not very good. So first of all, we have to rule out any anatomical problem if it is there. In case or there is no anatomical problem and it is only because of peripheral effect of clomiphene, we can either wait for a few days if the follicle size is small. So effect of, especially for letrozole, effect of letrozole will go off and endometrium will develop. Even for clomiphene, effect will 90% of the time it will go off and the endometrium will develop in 2 to 3 days. In case the follicle size is big and we cannot wait for a longer time, we can add estradiol, or we can add adjuvants like nitric oxide donors, sildenafil, aspirin. We can add aspirin. Usually I don't prefer to add before ovulation, because NSAIDs can affect the ovulation, but nitric oxide donors and sildenafil, they have a very good response. And if uh, lining is very thin, then we can add estradiol also. Any other comments, Dr. Jindal, if you would like to add for
I
this?
would prefer to add estradiol early, especially in letrozole cycles, because in letrozole the basic problem is or the mechanism of action is reduction in peripheral estrogen levels. So actually the estrogen is low, so addition in these patients early generally do help.
Okay. So moving on to the next problem, multiple follicles. This is also mostly seen with clomiphene only. So multiple follicles means we are doing ovulation induction, and in case of unexplained infertility, superovulation. So more than 3 follicles is usually considered for such a patient to be abnormal. So we can either cancel the cycle or we can continue, but we have to counsel the patient about the risk of multiple gestation. And then the role of HCG, whether we should give or not give. So I would like everybody to give a response. So what do you prefer? Do you prefer giving HCG, or you prefer to tell the patient to do naturally?
Binakshi?
I'll like to give HCG. As we are following at our center also, ma'am. HCG trigger.
Yes, so most of the time I think we are giving HCG, but sometimes a lot of patients, they don't want any injections. They think any injection is interfering with their natural conception. So in those patients, we can go ahead with the with if if we have to see if they are having regular intercourse or not, because if they are having regular intercourse, they can go ahead and try naturally without giving HCG, because anyways the follicle will rupture. and we can check after around 48 to 72 hours whether this egg follicle has ruptured or not. In case where timed intercourse or IUI is required, definitely we have to give HCG.
I think that's a very good line of action, that in such young patients, early first cycle, second cycle, you don't have to give HCG. You just because mechanism is there, rupture should occur naturally, so there is no need. But timing, obviously, you have to do. And if timed coitus and IUI is required, like supposing husband wife are staying separately, then it's better to time it with HCG. Yeah, I fully agree.
So this is what I was talking about, the stair step protocol. It is commonly followed in letrozole. So we start with letrozole 2.5. Then we see the response 5 days after the last pill. That is around day 12. So we can see the response on day 10 also. If response is not there, we can go ahead, we can increase the dose to 5 milligram for 5 days, then repeat ultrasound. If still a response is not there, then increase to 7.5. Still response is not there, then increase to 10. This we can do, and usually response by that time is there. And if even with 10 mg response is not there, then preferable to cancel the cycle, and addition of gonadotropin should be done for such patients. And similarly, if we are not increasing the dose, we can increase the duration of the same dose. So we can increase the duration to 7 days to 10 days if 5 days response is not there.
Ma'am, we have a query in our chat box. So, ma'am has asked, can you name any nitric oxide donors? As commented.
We have most commonly the arginine sachets that are there. That is the most commonly used nitric oxide donor, and it gives a very good response.
Okay, thank you.
Okay. The clomiphene also stair-step regime is used. Start with 50 milligram. If response is not there, we can move on to 100. If response is not there, we can move on to 150 also. We usually don't go beyond 150. So these are very commonly used terms earlier when we were not using letrozole. So clomiphene resistance and clomiphene failure, what is the difference and how to manage both of these? So basically the difference between resistance and failure is that clomiphene resistance is ovulation failure, that is failure to ovulate with 3 months of use at 150 milligram per day. That is the commonly used highest dose, and it is seen in about 20% patients of clomiphene. And clomiphene failure is that pregnancy has not occurred even after 3 ovulatory cycles. So these terms were the commonly used ones earlier. There is for letrozole, these terms are not preferred, but usually management of both is same, even if patient is showing letrozole resistance. So in cases of clomiphene, why clomiphene failure occur? Multiple reasons may be there, because of anti-estrogen effect on the endometrium, on the cervix, because of decreased uterine blood flow, and sometimes biochemically they say that clomiphene impairs the placental protein synthesis and it can affect the tubal transport also. So how do we overcome clomiphene resistance? That is, ovulation is not occurring with clomiphene. And similarly for letrozole also, we can follow the same protocol if ovulation is not occurring with letrozole. First of all is prediction. How do we predict that this patient can be resistant, or she may not respond to clomiphene or letrozole? In case of obese patients, those who have more insulin resistance, those who have hyperandrogenism, and if a level of AMH is very high. So sometimes patients come with the levels of AMH around 10, even 9, 10 nanogram per deciliter. Those patients are unlikely to respond to oral drugs. So these factors we can use to predict before starting the ovulation induction. And then once we have predicted, like if the patient is obese, showing insulin resistance, and we can go ahead with the higher dose. The starting dose only should be higher. So instead of starting with 2.5 of letrozole or 50 milligram of clomiphene, we can move on to the higher dose, like either 5 mg or letrozole for 10 days, or 100 milligram dose of clomiphene we can start for the first cycle. And Prolonged use can be done or higher dose, and we can also add adjuvants. Steroids, like here comes the role of insulin sensitizers that we discussed earlier. So insulin sensitizers are especially with the obese patients and those who are insulin resistant, adding them to ovulation induction will help have a better response. And other corticosteroids also have a very good response in these patients. Adding a minimal dose of dexamethasone for 10 days along with the ovulation induction, which shows a very good result. And if hyperprolactinemia is there, we can add dopamine. And gonadotropins are definitely there if everything else fails. Preliminary suppression earlier was used very commonly in PCOS, but now with better regimes and better drugs and gonadotropins coming along, we are not following this because it increases the time.
I think this was one of the questions by Dr. Dechen, that how do we handle the high LH?
Yes, for high LH, we can give preliminary OCPs, but in that also actually LH is very variable, so it is not mandatory that we should give OCPs even if LH level is high.
And actually, LH levels do not affect the outcome of ovulation induction. So there's not LH is used only for diagnosis purpose. So don't go after suppressing LH too much. Yeah, continue.
Anything? Yes.
No, cut.
So this was a latest study in 2024. It was a systemic review done on combined letrozole and clomiphene that we were talking about earlier. So it has very few studies, only 4 or 5 studies are there in this review. But they have combined letrozole and clomiphene, starting both from day 2 for 5 days. So both of them they have given, and they have seen that significantly higher rate of ovulation was there with a combined uh, uh, regime compared to only letrozole. And but the quantitative analysis of conception, clinical pregnancy rate, the results were not significant. Adverse events were similar, but hot flushes they were seen more with a combined dose. So this can also be used if there are chances of insulin resistance, like if we see that patient is obese,
लेकिन आइयो ओरियो में दूसरा केक मंगवा रही हूँ उससे
or those that in those patients where we can predict that resistance will be there, we can take a combined approach also for these patients.
I think we need more studies on this before we recommend this to.
Yes, definitely. Very few studies are there for this. So this was the problem of response. Another problem is side effects. Definitely side effects can be there with the clomiphene. As with clomiphene, there are more; with letrozole, they are less, but still it may be there. The patient may have hot flushes, mood swings, visual side effects, but these are all temporary. So we have to counsel and reassure the patient, and we have to definitely stop the drug, whichever drug is causing the problem, and then we should cancel that cycle, and in the next cycle we can consider another agent, or we can consider gonadotropins.
I would like to say about visual side effects. Actually, they are very rare. I initially I used to think ये थोड़ी होते हैं कभी किसी को. But I've seen patients with blindness in one eye who had, used clomiphene only one cycle or 2 cycles. So any visual symptoms, please do not ignore and just stop CC and use alternates. Then there's another question regarding OHS's use of cabergoline. Whether you would use cabergoline with normal prolactin levels.
Yes, definitely. In cases of OHSS, if we are seeing a hyper response for prevention of OHSS, cabergoline is very effective because it decreases the VEGF levels. So we usually give gonadotropins 0.25 daily for around 10 days. It can be given vaginally if the patient can take.
There is another query. Ma'am has asked, can we give clomiphene citrate and estrogen together?
Yes, we can give. Not starting. We should not start with the clomiphene and estrogen together. We can, after a few days, like we discussed, the poor, there is endometrium is poor, then we can start with estrogen, because with clomiphene, thin endometrium will be there. We can give estrogen in those cases, and in few combinations are come in the market where with every clomiphene regime they are adding estrogen. I don't prefer to give estrogen in all cases, because lot of times clomiphene will have a normal endometrium only. Instead of estradiol, I prefer to add adjuvants like arginine or aspirin I add. But usually estradiol I give only to those patients where endometrium is very thin on monitoring. For if we are not monitoring the patient, I don't think we should give estradiol. If anyone else would like to add anything on this.
Yeah, I think without monitoring, no estradiol, because you cannot judge. Unnecessary addition of medicines should be avoided.
Because some IVF centers are using both the drugs together, right from the day 2 or day 3.
No, no, no. At
Hmm.
least I don't agree to that. It's
Right, right.
given only if
Huh.
required. Yeah.
Okay, okay. Thank you.
Because we are talking about patients, these are patients who are coming initially. matlab, for IVF centers, like ma'am said, the patient clientele will be very different. So these are the patients who are coming initially, for those we are giving the oral drugs. Then the main question, why letrozole was banned, like when I was doing my fellowship, we were not using letrozole because it was banned, because a study had come which had shown congenital malformations with letrozole. So this is of prime importance. We should not be causing any problems, because we are giving the patients this to get pregnant. So we should not have any iatrogenic congenital malformations. But now lot of studies are there which, and on many patients, around 600 patients, 900 patients, studies are there which have shown that there is no risk of congenital malformations either with letrozole or with clomiphene. And especially with letrozole, it is a short acting drug, so mostly the effect of the levels of the drug will decrease by the time of implantation. So in fact it vanishes by the time of implantation, though, so chances of it causing congenital malformations is very less. And another big question is, for how long can we give the ovulation induction? Especially in India, patient is bouncing from multiple doctors. They are going to RMPs, they are going to Ayurvedic doctors, and everybody is giving ovulation induction, clomiphene, letrozole. There is no check. So how long we can give? According to RCOG guidelines, we should not give more than 12 months. And this is for clomiphene. For letrozole, there are as such no guidelines, but we can follow the same protocol. We should not give more than 12 cycles for one patient. That is also, according to me, very long, because that if patient is not conceiving even after 12 months, the time to pregnancy has been increased a lot. But basically it is to avoid the risk of borderline ovarian tumors. However, there is no conclusive evidence that the multiple ovulation induction will cause ovarian tumors. Only study that has shown increase in risk of borderline ovarian tumors was in nulliparous women who have been given ovulation induction. But whether the risk factor is nulliparous woman or the risk factor is multiple ovulation induction, that is still not conclusive. So we can consider ovulation induction to be safe regarding ovarian cancer, but it should not be indiscriminate.
Manishi, we can little move faster.
Yes.
Yeah.
So with this, we have discussed first line. So coming to the role of insulin sensitizing agents. So insulin resistance is the basic pathology that is there in PCOS. So most commonly used drug for this is metformin. It decreases gluconeogenesis. It increases the peripheral uptake of glucose. Other drugs that are commonly used are combinations of minoxidil and dechironositol. which also decrease the insulin resistance and increase the chances of ovulation. So metformin has a lot of advantages. It is easily available, though the use is off-label, but it has a very good result in PCOS patients. Only disadvantages are that gastrointestinal disturbance is very common, and it decreases the absorption of vitamin B12. For that, we can add vitamin B12 along with the ovulation induction. So patients, to decrease the gastrointestinal side effects, patients should be counseled to start with 250 to 500 milligrams daily, and then increase to 500 to 750 milligrams. 3 times a day can be given. What are the recommendations? So, like we discussed earlier, metformin can be used alone, but the effect is not very good. Inositols are, as such, not recommended in any of the guidelines. They are considered experimental therapies, though they are being used in and out, and they definitely have very good response also. Only problem is that they are expensive, and side effects and safety profile are not very well documented. Other anti-obesity agents are should be used only in research settings, and they cannot be recommended right now. So coming to anti-obesity agents, what other options are available right now? So coming to the new kid on the block, the GLP-1 analogs. They are very good drugs. They have been introduced for diabetes. They are basically increase the glucose dependent insulin secretion from the pancreas. They suppress glucagon release from the liver, and they slow gastric emptying. So when they were released for diabetes, but the response for to obesity was so good that now off label they are being used very commonly for obesity. And coming along with obesity is PCOS. So it is not as such recommended for PCOS, and but research is ongoing, and people are using GLP-1 analogs in PCOS, and response is good. But as such, starting off, it is not as such recommended, but we can give to obese patients because it will cause metabolic improvements. It will improve the hormones. Like we are giving lifestyle for those patients who are not able to follow the lifestyle management and they are morbidly obese, we can consider GLP-1 analogs. So, a word about unexplained infertility. Till now, we have talked about anovulatory infertility, which is the most common use of oral ovulation induction agents. For unexplained infertility, especially in the Western literature, a lot of people are recommending that straight away these patients should go for IVF, so to decrease the time to pregnancy. But it is very difficult to explain to the patient that for unexplained infertility, that directly you move on to a higher treatment, because a lot of patients will respond also to oral drugs. Various RCTs, though, they have shown that there is no difference in the pregnancy rate for unexplained infertility in if we are giving placebo or we are giving oral drugs. There is no difference in the pregnancy rate, but still it can be used as a first line treatment for young patients because of the advantages. The cost is low, it can be given orally, there is less need of monitoring, there is less chance of multiple pregnancy. But what the studies have shown that to decrease the time to pregnancy, we instead of giving the timed intercourse, we can add IUI to the clomiphene, and then we can straight away move on to IVF in case the IUI fails. So that is a better method instead of going for first CC plus IUI, then gonadotropin plus IUI, and then IVF. But all this we have to discuss with the patient, whatever they are comfortable with. But definitely we can, for initially, we can give oral drugs for unexplained infertility also. What are the latest recommendations? Recommendations are that if the patient is going for timed intercourse for unexplained infertility, there is no use for oral drugs, but we should combine clomiphene with IUI. That has been evidence is there that it is superior to expectant management as compared to natural cycle IUI, and but chances of multiple pregnancy are there. And in case of letrozole, that also can be combined with IUI for unexplained infertility, which gives a better result as compared to timed intercourse, or natural cycle IUI. So what is important here is that it should be a patient-centered care. A lot of people will not like to take injections. So we cannot straight away add gonadotropins to patients with unexplained infertility. So we should at least consider for the first few cycle a higher dose, like we can give 5 milligram of letrozole or 100 milligram of clomiphene for these patients, and they can try with the oral drugs also. But say at the same time, we should not waste their time also, because time to pregnancy should also be a consideration in these patients. To
One
conclude,
doctor has
yes.
asked a question as to how many sittings of IUI can be done in such patients.
So in such patients, the recommendations are that different recommendations are there actually. The RCOG guidelines recommend 6 cycles of IUI, which can be done in such patients. But usually after 3 cycles of IUI, it is better not to waste time. And in case we are going for 3 or 4 cycles, we should add gonadotropins with after 2 cycles. We should add gonadotropins if we are going for 3 or 4 cycles.
There is another query, ma'am. Can berberine be recommended instead of metformin in PCOS?
Yes, berberine also, very few studies are there. It can be given. I don't have any experience with that actually. If anybody else would like to say, if anybody else has any experience, studies are there definitely, but not a recommendation. The recommendation is not there. Or Dr. Jindal, if you would like to say anything.
Berberine we have also not used. Actually, a lot of these things keep on coming, but without evidence, it's not possible to introduce in the practice. See, basic principle is this, that you should not prolong treatment. What I tell patients is, if treatment is working, it will work in 3-4 months. If it's not working, then at least don't waste your time, money, body, energy. Even natural pregnancies do occur, especially in unexplained infertility. Young patients, I think wait and watch is a very good policy rather than giving medicines, continue the medicines. 3 or 4 cycles of ovulation induction, 3-4 cycles of maximum 3 cycles of IUI, they are good enough. No treatment, or then you shift to IVF. IVF, early IVF decision is actually the best policy. Early means, in like this patient, if we think that she's 31 years, she was 28 years, 28
26.
years old female. So just
Yes.
3 years infertility is a good enough time to tell you that it's not working. No other treatment is working. You don't have to wait for 5 years, 10 years, or her to become 33 or 35 to take a decision of IVF. So treatments usually work in first 3 months. Otherwise, they don't work.
So
Are there any recommendations in cases of luteinized unruptured follicle, like what agents to follow?
For luteinized unruptured follicle, if it is proven, then the only treatment is IVF. It will no
Proven
drug.
and recurrent. Proven and recurrent.
Proven
If
and
it is an
recurrent.
occasional cycle, you can try another cycle, use the different agent. Like for letrozole, usually LUF is less. LUF is more common with CC. So letrozole you can use. If it's recurrent, then usually there is some problem with the ovarian capsule or the rupture mechanisms, and then only treatment is IVF. The other things, increasing the dose of HCG, doubling the dose, and all those things don't help.
So to conclude, the first line treatment for PCOS is letrozole. And in case of resistance to letrozole or clomiphene, we can add adjuvants like insulin sensitizer, dexamethasone, or we can go ahead and add gonadotropins. For clomiphene, we should give a maximum of 12 cycles. For unexplained treatment, infertility, first line treatment, we can give clomiphene, letrozole along with IUI. And most important is we should give an individualized approach. We should see what is the need of the patient, what is the age of the patient, what is the cause of infertility, and how to approach the patient, how much the patient can afford. And when coming to affordability, definitely the oral drugs are less expensive, but we have to explain to the patient that they should not waste time, because even with oral drugs, if for 2 years if they are taking, they have wasted lot of time and money. So the approach should always be individualized. Thank you
Uh,
for the patient hearing.
we have a query from Dr. Usha. Can we give second HCG trigger? I think in luteinized unruptured follicle, ma'am is asking whether we can give a second HCG trigger.
Yes, we can give, but I think for a simple cycle of clomiphene or letrozole, we should not be worried about LUF. We can change the agent, that is preferable, because increasing the dose will not usually work for such patients.
There is another query, ma'am. Is there any role of DHEAS and N-acetylcysteine in PCOS?
DHES is used mostly for poor responders because PCS is already a hyperandrogenic state, so we should not give additionally DHES. And N-acetylcysteine, definitely it has a role, but insulin, it is not as good as using insulin sensitizers. A lot of companies, they give combinations of N-acetylcysteine and insulin sensitizers. A lot of studies were there initially for their use in PCOS, but it is not a very well established role, or it does not give very much additional benefit for PCOS.
Any
Anything
other
else?
any other queries? You can please put up the comments or you can unmute yourself and ask directly.
Manishi, do you have those slides of next?
Yes, yes.
Ma'am, we have another query. Is there any role of vitamin D in such patients in PCOS?
Definitely, vitamin D has a role nowadays. Vitamin D has been proven as affecting all patients of infertility, right from PCOS to poor responders to unexplained infertility. And I think we should give vitamin D. We can do vitamin D levels, but as a routine, it is not mandatory or necessary to give, but it may help if the levels are low.
I think vitamin D is more of a health supplement, and practically everybody is sun deficient and vitamin D
Patient,
deficient
yes,
these days. So,
yes.
vitamin D supplementation should be done most of the time. People are deficient.
But we should also check that patient has not been taking vitamin D from any other doctor, because
Yeah.
everybody will be giving vitamin D. So we should not.
Hypervitaminosis is a problem with vitamin D. So please don't
Yes.
overdo it.
So this was the first session on the second series, and we would like to meet everybody for the next round. And it is at next Friday, 6:30 to 7:30.
Yeah, 15 day after 15 days,
After
Manishi.
15 days, sorry, on 14 November. From oral, we will be moving on to gonadotropins.
Thank you, ma'am, for such an informative session. And
Thank you so much for giving me the opportunity for this. And
ma'am, we have a query. HCG doses. One second. Ma'am, HCG dose 5,000 or 10,000, which one should be used?
for basic ovulation induction, 5,000 is enough, I think. I usually give 5,000 only. For 10,000, I only give to patients who are maybe for endometriosis or in IUI cycles. For those also, I give 5,000 only.
Maybe
Uh,
weight related.
right.
If obese women, you might consider 10,000.
Yes.
Yeah.
So I hope we have answered all your queries. Thank you, Manisha ma'am, for this beautiful session. And thank you, ma'am, Jindal ma'am, for your expertise during the session. Thank you to all the participants for the patient hearing. And we hope to see you soon on 14th November for the next session.
Thank you very much, everyone. Thanks for your encouragement, for your questions, and really participating in the session. And we hope that next sessions are more and more interactive. And we would thanks for your encouragement.
Thank you so
Yes,
much,
we'll
everyone.
we'll give you recording on Monday. Somebody is asking, we'll give you on Monday. I think with that, I take your permission to close the session. Thank you, everyone.
Thank you. Thank you.